Hello, everyone, and welcome to the ONC and CMS Information Blocking, Interoperability, and Patient Access Rules session. That introduction was a mouthful. We will give it probably 30 seconds to a minute to allow some other folks to trickle in from the keynote, and thank you guys all for joining. Great. Well, I'm looking at the attendee list, and we have upwards of 300 folks, so I'm going to just get started here. So for those who don't know me, my name is Austin Dobson. I am a product manager here at Lineate. I have a background in public policy and focus on our API and FHIR products, as well as do some of the research into a lot of these state and federal rules. With me today, I have Abigael Grippe, who is a strategy analyst responsible for looking at healthcare industry news, regulations, changes, and how it impacts our customers. So we are super excited to talk to you guys today. Great, so let's jump in. So what we are going to talk about today. So the details of CMS and ONC rules, what are the rules, who's impacted, and how. I think these are probably the three biggest questions we get here at Lineate is am I affected by these rules? Oh, I am affected. How am I affected? What do I need to do to comport with these rules? So why does the health IT industry need these rules? I think it's a really interesting conversation that gives a little bit of context to the origins of these rules and why they were implemented. Obviously, the implementation timeline is super critical to understand. And next steps, how do we solve these problems? There is no one-size-fits-all compliance solution, but we here at Lineate are very eager to help you on your compliance journey. So we will talk through all of that as well. Great. So we have CMS interoperability, patient access, ONC, information blocking rules explained. And I promise that will be the last time I say the entire title of this session. It is a lot of words. Great. So what I put in here is the organizational structure of the largest federal agency by budget in the U.S. government, which is Health and Human Services. So Health and Human Services oversees all of the federal agencies that relate to domestic healthcare in some way. The two rules that we're going to be talking about today come out of two agencies within Health and Human Services, the Office of National Coordinator for Health Information Technology, or the ONC, which is starred here at the bottom, as well as Centers for Medicare and Medicaid Services, which starred here as well. And the reason I put this slide in, other than showing kind of how complex and bureaucratic our federal government is to emphasize that these are two rules from two entirely separate federal agencies within our government that were released in tandem. They have complementary enforcement mechanisms and complementary implementation dates and milestones. So this was a really concerted effort by HHS to coordinate across two disparate organizations to create a framework that covers, almost all like domestic healthcare agencies to better the goal of creating more interoperable healthcare. Obviously, Lineate is an interoperability company. This is kind of our passion. So we're really keen on understanding these rules, building products and solutions to help our customers abide by these rules. And that's kind of why we're here talking to everyone today. Great. So what are the CMS and ONC rules? So let's actually anchor ourselves in the two agencies that have released these rules. So first, CMS interoperability and patient access rules. So CMS is the Centers for Medicare and Medicaid Services, as I said, and the lever that they have that is how they enforce these rules is they control Medicare reimbursement dollars. So any healthcare agency that receives Medicare reimbursement needs to comply with these rules, or the penalty for noncompliance is a downward adjustment of their Medicare reimbursement dollars, which obviously is a huge revenue stream for so many health systems in America today. So that's how CMS is mandating compliance, and the ONC is the federal government's agency that certifies all healthcare technology. So obviously, if you were selling technology to the government, you need to have ONC certified technology, but many, or I would say even most RFPs that we see require that any organization that's bidding on state contracts, even private industry contracts, they want to see that your technology is certified up to these ONC standards. So that's how the ONC is going to require compliance, is say you need to hit these technological hurdles for your product to be certified by ONC, allowing you to sell to state and federal agencies. And obviously the private, the private sector also listens very closely to that guidance and says, hey, also we want to know that when we're buying technology for our hospitals and health systems and payer organizations, that it is also certified up to this very high threshold. So that's kind of the enforcement mechanisms that both CMS and the ONC are using to ensure compliance across a whole array of agencies within the United States. So let's jump into the rules themselves. So mandating as a condition of participation in Medicare, provider organizations need to have a patient access API. So this is the big one. This is probably what most on this call have heard of, if anything related to this rule, is you need to have a FHIR R4 API that surfaces patient information that the patient, if I'm the patient, can query with an application on their smartphone or their computer to call back all of their protected health information, their entire medical record, so that patient can then be a better steward of their clinical experience. So this is the big one. There's a ton of hurdles in standardizing all of your data stores to be able to expose all patient information that your hospital or health system holds as FHIR. So this is probably the part of this regulation that's been getting the most attention. Second, we have Provider Directory API, which is basically showing who is in and out of network and what services are covered. So again, giving the patient a bit more consumer choice when they're looking around to say, hey, I need a knee replacement. These are the organizations in my region that can cover it. These are the providers that can cover it. So a little bit of transparency around who's in and out of network in your area. A third large one is payer-to-payer data exchange. So the way I think about this is patient access is a single patient resource that is surfacing one patient's data. Payer-to-payer data exchange, people talk about it as kind of bulk FHIR data exchange. So this is the idea that you can send entire claims history of a patient or a group of patients, and for payers, they're members, so member roles between different payers. So if I, funny enough, in the States, I think it's above 80% of our health insurance is, or 80% of covered people in America get their health insurance through an employer. So as you change jobs, you want your claims history to migrate with you. So the idea here is that as you change jobs, you can request that, hey, Blue Cross Blue Shield in Massachusetts, I want you to send all of my claims history to my new insurer, Aetna or whatever it may be. So this is also a big lift for payer organizations looking to comport with these rules. State, federal data exchange. So this is the idea that HIEs and state departments of health can communicate with federal agencies. So there is that data liquidity at the state and federal level. Digital contact information, self-explanatory. Admissions, discharge, and transfer event notifications. So this is ADT feeds. And many healthcare organizations have ADT feeds. The one thing I will say is these ADT feeds need to be inclusive of every point of care within a health system. So if this is at a skilled nursing facility, if this is at a specialist, all of those individual events need to be communicated via ADT feeds. And moving to the ONC side of the house, so this is obviously certifying that your technology is capable of completing these actions. Patient EHI access, so this is the ability to stand up that FHIR R4 API facilitating patient access. A big part of that FHIR API is how you authenticate the patient that's getting access to their data, right? Because this is just an API that's on the public internet that anyone can hit. So if you're a healthcare organization, you need to think, how can I secure this API, ensuring the person that is requesting their clinical data is the person that should have access to that clinical data? And there's a lot of nuance there. So this is certifying that your technology has OAuth 2 for patient access, which is a really critical piece of securely providing that patient access. So that's kind of the overview of the CMS side of the house and the ONC side of the house. But what I do want to emphasize is, because these are two separate federal agencies releasing these rules in tandem, the overarching thrust of these rules is to create an ecosystem where if I'm a patient/member, I can get all of my clinical information from any point of care and have complete ownership of that. So that's my claims history when I move from a payer to another payer. That's my entire clinical history across kind of my entire journey within the healthcare system, which can go back years and years and years. Great. So as Christian Bale, one of America's finest actors, is conveying with his confusion here, am I an affected actor? So the way both CMS and ONC define someone who is affected by these rules, they call them affected actors. So, what I want to get through with this slide is almost every organization, any healthcare organization in the States that has protected health information in data stores is an affected actor. So all hospitals and health systems, all payer organizations, health information technology companies that have patient data, health information networks, and health information exchanges. So again, casting a very wide net across two federal agencies with separate sets of rules. But again, the takeaway here is they're really trying to have this set of interoperability rules be almost all-encompassing. So wherever you are as a patient, whatever organization has any of your patient data, you should be able to access that data. Great. So next we have, skipping ahead here. Next, I'm going to pass it off to Abby, who's going to talk a little bit about the implementation timelines and some of the other fun nuances of these rules.
Awesome. Well, that was a great overview, Austin. You have definitely been living and breathing these rules for quite some time now, so it's probably just so repetitive at this point. You're able to just kind of spew it all out there. So that was super helpful for all of us. And the implementation timeline of these rules. So these laws were published back in 2020. So again, we've kind of been living with these final rules for some time now. So far, the ADT notifications, the patient access API, and provider directory API are all in effect. The next big piece of legislation that Austin described is that payer-to-payer data exchange. So payers are required to exchange patient data as a patient moves or a member moves from plan to plan. This piece most recently was delayed by CMS. So there's a enforcement discretion around this part of the regulation, but still important to know all of the different nuance associated with this part of the legislation in particular. Not slowing down on other pieces of this final rule, and CMS is also still encouraging payers with the payer data exchange to have the ability to implement. If you have the ability to implement this exchange, please do so. That's kind of the message from CMS at this point in time. But we will be keeping track of final regulation as it comes out, further defining that piece of legislation. So reach out if you have any questions as things become finalized. Two outstanding pieces that are not yet required under law, obviously, would be that eligibility state-to-state data exchange, and then also the TEFCA piece was removed from final legislation. So just wanted to kind of just give a high-level overview of the implementation timeline. The next piece we'll get into is why were these rules enacted? You know, as Austin mentioned, interoperability from every piece of the healthcare ecosystem is the major goal of these rules. Here we have meaningful use as part of the HITECH Act was initially put out years ago in order to improve data exchange, but ultimately the purpose of the meaningful use legislation was to encourage the adoption of healthcare information technology, but in turn it actually created large data silos, and true interoperability was still missing. So that's part of the reason why these rules were enacted. By limiting the availability of electronic health information and creating these large data silos within electronic health records, it in turn weakened competition among healthcare providers. Patients weren't able to move from payer to payer or from provider to provider as easily. So patient choice is definitely a big piece of these rules. Also limiting the availability of EHI was creating barriers for entry for new innovative applications technologies. So with these rules, we're starting to see the promotion of the ability of all parties within the healthcare industry, as Austin mentioned, payers, public health, providers, HIEs, to communicate seamlessly across various software platforms and electronic devices. So super exciting from a patient point of view, definitely increased patients' access to their healthcare information. So as all of us are consumers of healthcare information, we should be super excited about all these changes. But in turn, as people within the healthcare IT industry, it does mean that there is some work to do. And I guess, Austin, as you've sort of been involved in a lot of these different, you know, in the preliminary final or in the preliminary text and then the final regulation, what are anything else that you have to add here? I know there's a lot to these rules.
Yeah, that's a great question, Abby. So I guess what I would say here is, for those, you know, I think most everyone on this call is probably somewhat familiar with the history of meaningful use. I mean, that impacted health IT for almost a decade, and we're still seeing the implications of those rules. We should be thinking about the 21st Century Cures Act and the promoting interoperability rules in the same way, that this is going to be a multi-year initiative that the federal government undertakes to dramatically change how patients interact with their clinical data nationally. So, you know, some folks have reached out to us and said, you know, hey, Abby and team, like, you know, we saw that the CMS is you know, pausing enforcement for some pieces of this. Like, does that mean I don't have to worry about it? I would say, like, definitely not. Like, this is a multi-year initiative that the ONC and CMS is rolling out, and it's a massive focus of HHS. So this is going to be a continued focus. So, you know, I think as we're doing these presentations, like, I think it's incumbent on our community to really start thinking critically about how, you know, your organizations will change as a result of these rules, and what systems, interoperability systems, you should be putting in place today to get ahead of those changes.
Right. Great, thank you. All right, we'll go to the next slide here. Okay, so with all of that being said, there are consequences for noncompliance with these rules. a few things to call out. Currently, health IT developers of certified health IT, health information networks, HIEs, do have civil monetary penalties involved in that's currently being engaged with Health and Human Services currently with the Office of Inspector General. So just noting that, right now it's just citing that there could be a civil monetary penalty up to $1 million per violation, but nothing is established just yet with enforcement dates. So, we'll be on the lookout as that final text is rolled out further. And then also for healthcare providers. So if you are a healthcare provider and you're non-compliant, again, HHS and OIG will engage in future full rulemaking to establish disincentives. So just kind of calling out here that there are implications to being non-compliant with these regulations. And then the last piece, conditions of certification require that a health IT developer is responsible to ensure that all IT or all health information is able to be accessed, exchanged, and then the use of electronic health information. So just wanted to call out the non-compliance piece of these regulations. It can be scary when you see that $1 million fine, but just know that currently, nothing has been established just yet. There is still rulemaking that is happening currently. All right, so here we'll kind of deep dive into a few different pieces of these rules. The CMS and the ONC interoperability and patient access rules as a whole. So what does this mean for interoperability? There will be a push for provider and payer organizations to adopt FHIR API endpoints, as Austin mentioned, to encourage patient access to health information. The adoption of the patient access API via FHIR will require healthcare IT vendors to expose this data. I have been seeing recently that there's a lot of different research showing that there has been currently a slow adoption of APIs, but will be increased. There will be an increase in FHIR uptake with it throughout through 2024. So just kind of noting there, largely due to these interoperability rules, that API adoption will steadily increase over time. More healthcare organizations and health IT vendors will be storing data in the FHIR standard. As Austin mentioned, authentication is a super critical step in all of this. All data requests will need to be authenticated in order to access that electronic health information. Outside of user authentication and the permissions associated with accessing health information, you need to make sure that you're securing your internal systems for external sources. That's a key piece here. So making sure that your systems have security measures in place for those external sources that are making those data requests. And then for the information blocking piece of these regulations, healthcare organizations will need to allow access to patient data and ensure that they have the technical ability to do so. Electronic medical records, health information exchanges, and payers will need to restructure their business model regarding how they deal with patient data. So making sure that you're not information blocking is key. Note there are some exceptions tied into the information blocking rules. So we won't go into them, but they are provided in the appendix attached to this presentation. So if you want to dive in a little bit deeper on those, certainly you can do so. And again, with the information blocking rules, many of your organizations have tons of healthcare data. So these laws have made it against the law to charge access to patient data. So yay for us consumers. We're able to get our health information without paying the $25 fee to do so. So exciting, but at the same time, it does require a lot on behalf of the healthcare ecosystem as a whole, whether you're a payer or a provider. Making sure that patients have access to the data has, different security measures and a lot of work to do. The next piece here that we'll kind of go a little bit deeper on is, where does healthcare IT fit in here? Payers will need to develop and update their provider directory. So as Austin mentioned in the beginning, when he was given the high level of each of the different pieces of the legislation, provider directories show which providers are associated with each health plan and the FHIR endpoint that's associated with that provider. So that's a piece that will need to be addressed. These regulations require bulk data transfer for large amounts of data to move seamlessly across the healthcare ecosystem. There will be an improvement to the accuracy of patient matching. That's a big piece. The ONC is particularly interested in ways that patient matching can help facilitate improving patient safety, care coordination, and overall just advancing interoperability as a whole. The other piece here to just call out where all this fits in with health IT is that electronic health information access, exchange, and use is restricted to the U.S. core data for interoperability, US CDI, for the first 2 years at a minimum. That's the minimum amount of data that you will need to send. Every organization that handles electronic protected health information will need to ensure compliance. So it really does affect every piece of the healthcare ecosystem largely. And then ultimately the next steps, understand where your organization sits in the healthcare delivery supply chain, ensure your organization is technologically capable of delivering US CDI data. Where does it need to go, and ensuring that it's in the required format according to these regulations. Ensuring your organization has processes and technology in place to transmit patient data via FHIR format. And then again, as we mentioned, restructuring and retooling information blocking business practices. So are you an information blocker, and how can you make sure that patients are able to secure the data that they are requesting? Huge pieces to this, to these regulations. Austin, again, anything to sort of add here that maybe I missed out on?
No, I mean, I think you covered it. One thing I will say, which gets glossed over a lot in these conversations, is there are different burdens to be compliant across different organizations. So I think we're going to talk about this a little bit later in the presentation, but I will say that, many folks will ask us, hey, but I thought Cerner said they're gonna do this for us. They're gonna provide the correct APIs. And what I will say to kind of that question is, today, none of the EMRs have fully certified that their technology meets the 21st Century Cures requirements. And also, because these are rolling compliance hurdles, it's in my estimation, like a fairly risky strategy to just, rely exclusively on the EMRs to provide those compliance tools. And yeah, that's the only thing I'd add here.
No, that was a great segue into our next slide here, which is, confusion remains around these rules. There's a lot to it. Again, like I mentioned, even the 8 exceptions that are within these rules is like, I mean, you could do a whole presentation, maybe even 2, on just the exemptions associated here with just the information blocking piece of all this. So, many healthcare organizations are aware of the rules going into effect. Like, they know that the patient access API and the ADT event notifications piece and the provider directory are all in effect currently, but many are still reporting areas of non-compliant practices. An example of this would be, like, again, including charging patient fees to obtain records or sharing records via paper or CDs. That's been called out in some of the research, secondary research that I've been doing. Many haven't made any changes. They don't even know how to ensure the facility meets requirements. Many healthcare organizations, again, using paper or CDs to exchange healthcare data. So just a lot of pieces to this. Again, unaware of the civil monetary penalties. Again, at this time, it's kind of just like a wrist slap, bad publicity if you are accused of blocking data. But eventually there will be fines, and those fines could impact smaller organizations or smaller HIEs that are accused of information blocking outside of the monetary penalty. Just the bad publicity, patients not being able to get their data, not a very good look. And again, just an overarching theme is like unaware of practices that would be considered information blocking. So I encourage you to reach out if you are still confused on any pieces of these regulations. I mean, me and Austin are just 2 of the people here at Lineate that have been sort of diving into these rules and figuring out what their implications are for our customers. So if you are still confused or would like to hear more about what Lineate's doing to help solve some of these problems, please reach out. Happy to help where we can. And again, Austin, just kind of including you in some of this conversation here, like, Why do you think healthcare organizations are struggling here? Is it the cost associated with meeting these regulations, or just really truly just confusion?
I think it's cost and confusion and like misalignment of incentives. So I think first, again, to the earlier question, like a lot of these organizations are being told by their leadership and EMRs, like, hey, like Epic has you covered or Cerner has you covered, so like don't even worry about it. And I would say, again, that's a fairly risky strategy. Second, like from the inception of the electronic medical record, what became increasingly clear was the data that medical record has becomes a revenue stream. And you mentioned on this earlier, Abby, that like all of these organizations are going to have to rethink how they structure like all of their kind of revenue models to take into consideration like, hey, you can no longer monetize this collection of clinical data that you have because the patients, you know, have the right to access that data whenever they would like to. So I think those are the big things that are leading to confusion and uncertainty.
Awesome. Yeah, and then we'll sort of go into, you know, bouncing off of the confusion piece, you know, what are the impacts to the industry as a whole? You know, things further to the left here obviously have a greater impact. Those to the right have a much lower impact. But for health IT and vendors, EMRs, you know, it's that vendor data sharing. That's a big piece, exchanging health data from one organization to another and not having it, you know, living in just one big EMR. It now has to be passed wherever the patient wants it to be passed to. For health systems and provider networks, it's that bulk sharing. And again, the patient data sharing, that's a big piece and a big impact to those pieces of the industry. Transmitting data on large populations of patients through FHIR, you know, huge hurdle to overcome and something that's completely new. So an example of this includes moving clinical data, you know, into an analytical data warehouse where these large volumes of data, clinical and claims data can be sent to enable the transfer of population level data and then do analytics on that data. So payers, again, the payer-to-payer data transfer, you know, at this time, there's going to be more final text around those, but huge lift for payers there. Let me go ahead. Next slide. Okay. And then common challenges to adoption and compliance and how to be ready. So, you know, FHIR is a completely new standard of interoperability. One of the core goals of FHIR was to create a standard that would lead to high adoption across disparate developer community. So it's focused on being easy for software developers to use. But what's cool about it is that currently healthcare organizations can coexist with and use FHIR. So, you know, we can use those older standards, but also embrace the ease of FHIR. So from here, we'll go into some ways that your organization can be prepared. As always, please reach out to anyone here at Lineate for further information to this. I mean, there's a lot more to that than just what's on the slide, but ensuring your organization has a compliance solution. So, you know, the first step is like understanding what these rules are and how they may impact your business. This is likely started for most of you. So, you know, but partnering with subject matter experts and us here at Lineate, we can help you guide you through the onboarding process. Identify what systems you're connected to. So like Austin was saying, you know, not just relying on your large EMR that you might be already connected to, but what other vendors are you connecting to, and what, you know, making sure that you are compliant as an individual provider or payer or HIE. What format is their data stored in? So again, identifying what systems you're connected to, and then how is their data stored and what formats they use. Where is your protected health information housed? Need to identify exchange formats and translation needs, HL7 messages to FHIR messages. What are the requirements to get these messages into an appropriate format and then passed off? This obviously differs from provider, payer, space, but it also differs per organization in each of these segments because of the different formats that are used, HL7 versus X12 in the payer space. Understanding the authorization piece is critical, as Austin mentioned earlier in the presentation, and access to patient-level healthcare data, understanding your security model to send and receive data, again, authentication and access control, huge pieces to these rules, and how access is granted to this patient data. So understanding all of this is very, very important. From here, I will pass it off to Austin to sort of go into how we at Lineate have your back.
Thank you, Abby. Yeah, and the one thing I will actually jump back one slide, because I think that last bullet deserves like a little bit more time. So how can this new paradigm of data sharing benefit my business? I think we all get in this mindset a lot of the time. We're like, oh, shoot, like, we're being told we have to do this thing. Like, let's just do this thing and forget about it. What I think is really important for kind of everyone to think about is how can this new data liquidity paradigm benefit my business? So, a lot of the things we're just starting to hear about in industry is the development, like in-house development of smart on fire applications that you can then plug into those API endpoints to get new data, creating new clinical insights. And there's just really greenfield, like in the industry for like how your organization will benefit long-term from the 21st Century Cures Act. I know, I get in trouble a lot by just focusing on kind of the negative pieces of this, but there are ways that you can really, if you are forward thinking and have the resources and time, you can really take advantage of this new data sharing paradigm. And you have the tools to do it, because here at Lineate, we have obviously the industry leading interoperability tools. You'll probably hear that more than once for these sessions. Awesome.
Awesome.
So
I really like your positivity there. As organizations, like having to focus on the compliance piece is super. It's just like, here's what you have to do. So, putting a spin on it and something like this really does. The opportunity is endless. Yeah. So I'll let you go ahead, Austin.
Yeah, I did have my large Dunkin' Donuts cold brew this morning with no ice. So I am just really, really optimistic and fired up. So there we go.
Awesome.
Yeah, so let's talk a little bit in more detail about kind of what you should expect and how Lineate is preparing our customers for success in this area. So first, as I mentioned on the previous slide, like from all of the indications we're hearing, and also where CMS and ONC are signaling that they think there's going to be innovation, is in the app economy. So what does that mean? That means as a patient, I log into my iPhone, I download an app to track like some comorbid condition I have, whether it's high blood pressure, hypertension. I downloaded a hypertension tracking app on my phone. I request via FHIR my medical, my clinical history from my provider. I plug that plugs into my app, and then I can track my own condition on my phone to have much greater stewardship of like my healthcare journey and not be solely reliant on the EMR and my provider, though obviously they're going to maintain a very important role in my healthcare journey, but just another way for patients to be a little bit more empowered. So again, how do we benefit from that app economy that runs the gambit of like developing in-house apps, surfacing them through our integration engines? There's kind of many ways that organizations can lean into the emerging app economy that the 21st Century Cures Act is most likely going to facilitate. And number two, like I think we all know this on the call, Lineate is the infrastructure to build a connected ecosystem upon we can ensure future-proofing our organization for FHIR standards, as well as like future compliance rules. So as Abby showed in that implementation timeline chart, like these are rolling rules. Every 6 months, we have a new proposed rule. The most recent one is around prior authorizations. So ensuring that your organization has a platform to like plug in these new fire standards, new extensions of the fire standard to cover the new pieces of these interoperability rules that you're going to have to comport with. And again, not being reliant on EMRs, which, you know, I came from an EMR prior to this job. Like many people at Lineate have worked in the EMR space. Like they are very big monolithic organizations that are not necessarily as agile in accommodating kind of new rolling compliance standards as we would like. Third here is ensuring vertical and horizontal scaling, ease of implementation of new interfaces as adoption grows. So again, like whether you have CorePoint, Rhapsody, RAS, like our cloud offerings, like we have across all of those offerings, like vertical and horizontal scalability to onboard new connections, scale those connections, monitor those connections as adoption grows, as kind of you stand up more APIs. That's a critical piece of this interoperability ecosystem. And luckily, most everyone on this call is an existing customer, so you're way ahead of the game. And third here, I'll give a little shout out to the product that I kind of am the steward of, the Lineate's new Fire API gateway and management platform called Rapid, which if you tune in to our session at our cloud session later this afternoon, you'll hear a bit more about. But the overview is it's a CMS and ONC compliance API gateway and management platform with pre-built Drummond certified compliance APIs. So we've built out the provider directory API with Drummond certification. We have built out the patient access API, working on our Drummond certification for that API today. But this is kind of a purpose-built product specifically around both API style integration and most specifically like compliance APIs around the 21st Century Cures Act, because this is kind of a new exchange paradigm, and we want to be sure that if this is something that you view as a organizational boom, like you can get a purpose-built product to help facilitate those REST integrations. And it is backed by best-in-breed Fire server. If you do want to store that data natively in Fire to have that repository unifying your data source on Fire, that is something that the product comes with. Next on the list is our ADT feed integration. So we have built-in tools to connect those ADT feeds. We've also partnered with some industry leaders in providing ADT feeds across the continuum of care, ensuring that, again, you are compliant with that ADT piece of the compliance rule, and ensuring those ADT feeds are encompassing the entire continuum of care. And finally, obviously, massive shout out to our flagship products, CorePoint and Rhapsody, are both industry leaders in Fire, both have Fire R4 standards out of the box, which is kind of the enumerated patient access API standard is the Fire 4.0.1 standard. And Lineate's long-term vision, to put a very fine point on it, like product vision aligns really, really well with the ONC and CMS priorities. Like we want to facilitate data liquidity and, seamless patient access across, the entire healthcare ecosystem. Our products and services help facilitate that. All it takes is you to have a conversation with your account manager or reach out, and we can be much more active partners in facilitating that integration and facilitating compliance with all of these rules. Awesome. That is it for us today. Thank you again for sitting through the very riveting, like, federal compliance session of our Connect 21 agenda. Though it may not be the spiciest session, I think it is very topical for all of our customers to be aware of. So thank you for the patience there, and great questions. I see in the chat, there's probably 20 or so questions that we haven't got to, so we will definitely follow up with everyone in the chat who have not had their questions answered. So thanks again for everyone's time, and again, please reach out if you have any further questions, comments, feedback. So yeah, next session is our networking lunch led by my boss, the intrepid Jim Stoya. So please jump into that session, and look forward to seeing you then.
Awesome. Thank you.
Thanks, everybody.